So one of the things that I like is on this talk, and we kind of, as we break this down, on the echoes, we talk about microburst inductions, macro. And one of the key things to this talk is we're going to talk about these different induction techniques, when you would use it, how you would use it, and we're also going to go to the different formulations for which buprenorphine is available. And we're going to be able to break that down rather nicely. So first, starting off with the formulations, we have the film or the tablet. And largely what you go with, the film or a tablet, is driven by third-party payers in terms of what is their insurance going to cover. I've got plenty of patients who are their insurance will pay for this, but not the tablets, and vice versa. And I haven't quite figured that out. So the film generally dissolves within 5 minutes. The tablet takes a little bit longer. Our patients generally found that in having a Catholic-based population here in New Mexico is just letting the patients kind of say it's kind of like Catholic communion and kind of makes sense to them. Within the last year or about a year ago, the FDA did add an adverse effect for the oral preparations at an increased risk of dental caries. In talking with experts, basically, the feeling is if patients get their annual checkup on their teeth, that'll be sufficient. But I don't know that we just necessarily cover that specific adverse effect, and I just wanted to bring that up. And the study that compared them was the injectable, which is a nice segue into our next slide, is the injectable or implant. And I don't think the implant has been on the market in a while. I certainly have not used it in 4 or 5 years. With the injectable, we have growing clinical experience with it. And we now have products for which we can give patients for injectable. I tend to prefer the injectable for my young patients and patients who have failed buprenorphine in the past. Yeah, and then but as we've talked about with previous echoes, there are some additional requirements that are needed for the clinic. And then there is also a higher cost with the injectable as opposed to the strip. So oftentimes with the different formula with the injectable, you need a prior authorization. For self-administration, that's pretty widely accessible. It's been a long time since I've needed a prior authorization to write that. And feel free to add into the chat column on what your take is on that. And then also, just because this is being recorded, I'm also not looking at the chat, and we'll address questions that come up at the end of the talk. So looking at the package insert and how is the induction supposed to be done is basically we wait until patients are feeling lousy. To really define more objectively as a COW score greater than 8. And I think we have multiple patients that just aren't able to get up to that high of a dose. We're given some information on when they last took an opioid, so 12 hours since a short-acting opioid like fentanyl, and more than 24 plus hours after using a long-acting opioid. And I usually wait and we'll get into specific methadone dosing, but methadone is among the longest acting that we have. You can consider the subjective opioid withdrawal scale or the SOUS score and targeting at least a 17. I am less trusting of the SOUS score than I am the COW score, simply because patients are feeling extremely miserable by the time they start or are ready to do the induction. The outpatient is generally preferred to start with 4 milligrams as a test dose. And that's honestly what I do when I'm at an outpatient clinic too, or going to be treating the outpatient environment, just because the patient's going to be feeling so miserable. The tendency is I will right now and fast. And so they tend to I always worry them taking a bit more. And then basically repeating that 4 milligrams every 1 to 3 hours for a total of 12 milligrams on the first day. Realistically, everybody's starting to sneak in 16 milligrams just because that's where we're seeing the survival data is really the 12s, beginning at 12, 16 milligrams. And in the fentanyl era, I don't think any of us are surprised that there are few and far between our patients being maintained on 16 milligrams. And then it's okay to if buprenorphine or the complication that we worry about is that if it precipitates withdrawal, and if it does, then you're welcome to call the clinic. Alternatively, we're happy to help them here at the New Mexico Poison Center. Unfortunately, we're the only poison center in the nation that is doing addiction calls, and Rachel will put the number in the chat. But that's a free service for your patients, and same with you guys as the providers out there. If you've got questions or want to speak to an addiction expert, we're happy to do that 24/7, 365. So on the second day of the induction, basically take the total day of that first morning. I always like, and I think it's good practice for them to check in with the clinic or have the clinic check in with the patient. And I think this does a couple of things. One is it really helps let the patient know that we care. And this is a patient population that I think we've all heard, or if we haven't, Rich does a nice job talking about some of the stigma and some of the problems associated with that. And it just lets patients know that we care and we want them doing well. And second is it allows us to, answer whatever question or things they may have. Putting this into a relationship where they're at from a clinical standpoint, this is when they're first coming in for an induction. This is usually when they're at their worst or sickest. So it's kind of the opposite of heart disease or cancer, when their most advanced is near death. Here they're going to be sick. We'll put them into remission, maintain them in remission, and then their DSM or their number of symptoms are going to be decreasing. So again, really kind of checking in, give them that extra boost, I think is helpful. If day 3, if we need this, again, if the patient should at this point have their withdrawal symptoms under control. In the fentanyl era, generally speaking, they may not have some of their symptoms associated with cravings under control. We may need to kind of bump that dose from a total of 16 milligrams a day up a little bit to 20 or 24. But basically, once we hit day 3, and I generally like to wait about a week and reassess them, bring them back into the clinic before doing much more in dosing adjustments. As far as, and I kind of covered this briefly, but how long to wait, provided the package insert is given here and you're able to read those off very nicely. And the concern again is, how is this going to precipitate withdrawal? So in clinical practice, where I utilize this is basically asking a patient, how long has it been since your last use, and saying, I don't want to make it worse, and let kind of the patient know. And if it's been more than, and I personally kind of double these time frames. So if it's been more than 24 hours, they're sitting with a cow score of 0, and then I'm good to go with an induction. I think it's a little bit odd that they're not having withdrawal symptoms, but it just may be that they're not, that they haven't been, they may not go into full on withdrawal, but you're generally pretty safe by doing an induction at that point. As far as transitioning from methadone, and we have some of these patients, and I think this is applicable to the outpatient, whereas for one reason or another, their methadone clinic didn't work out for them. What we generally try to do is titrate the patient down to 40 milligrams of methadone or less for a week. Patients are generally pretty uncomfortable during this period of time. We'll do clonidine, ibuprofen, loperamide, trazodone, hydroxyzine, etc., for comfort meds, trying to help the patient get to that point. And then we'll do a test dose or a start at a 4 milligram and see, does it improve withdrawal symptoms? And if the answer is yes, great. Then I have no problem if we get a partial um, improvement in withdrawal symptoms, then I'll give additional um, buprenorphine to get withdrawal symptoms essentially under control. If it makes it worse, I then instruct the patient to call the clinic or to call us at the poison center. And for you as the clinician, then we need to make a bit of an assessment on, do we want to go, and we'll cover this next, is a macro dosing and approach and how miserable the patient is. So as far as what we're worried about is precipitating withdrawal. The reason for the precipitated withdrawal is that buprenorphine is a partial agonist. And basically, think of your graph, full on agonist and then step down to partial agonist. And basically the full agonists that are using heroin, fentanyl is is higher than that partial agonism effect, and basically will send the patient into withdrawal. We have had a few patients, especially in the fentanyl area, that have been that the withdrawal has been severe enough that required hospitalization, including ICU level management. Also, feel free to do comfort meds, so the clonidine, ibuprofen, hydroxyzine, etc. But I think the highlight or the key in this slide is let the patient know ahead of time of the precipitated withdrawals. Also, I found that of my patients that I'm starting on buprenorphine, about 80-90% is my estimation, have tried buprenorphine in the past from a friend, a previous prescriber. Doesn't really matter. But some of them are initially very hesitant to start on buprenorphine just because it made them feel miserable ahead of time. And I think given the challenges of the ruralness of our state and lack of methadone clinics, we sometimes need to talk patient or let patients know that is can happen and is associated with a precipitated withdrawal. So we're going to transition here more into maintenance dosing, but this is I meant to change this heading to be micro and dosing. So this is the Bernese method for dosing. So basically, orientating to this, on day one, Bernese used 1/4 milligram. So I basically will write the patient a 2 milligram strips and have the patient start cutting the strips up. In the hospital, this can be a little bit hospital dependent on exactly how they want to proceed with cutting strips versus using like the Belbuca, which is buprenorphine for pain, and then basically doubling the dose every day. So instead of the 1/4 milligram, then we'll go up to 1/4 milligram BID and increasing. The Bernese method allows for patients to continue using their drug of abuse, and it doesn't really move the patient doesn't experience withdrawal symptoms. I've kind of played with a few different ways of dosing with the Bernese method, and overall, the most patients, I think the Bernese method is a little bit conservative. I've had good experience starting patients on a 1/2 milligram a day, so 1/4 of a strip instead of having them cut that 2 milligram strip into eighths. And then just over the course of a week, they get up to 12 or 16 milligrams, and then we bring them back to the clinic and reassess them. The FDA does allow up to 32 milligrams of buprenorphine a day. However, the insurance generally will cover only 24 milligrams. Again, in the fentanyl era, our patients are needing anecdotally higher amounts of buprenorphine, and when we have applied or pushed forward prior authorizations, usually document the patients failed at 24 milligrams, and within a month or so have generally been able to get the 32 milligrams approved. As far as the duration on how long to be on buprenorphine, and and how long to write the first prescription. I personally, and some of this is just what your clinic allows, but I like to follow them a week out, and then basically weekly until they're stable. Again, this is kind of the reverse of most chronic diseases where they're at the sickest when they start with us and then they get better. And my patients who are doing fine and in full remission, like I'll see them once a month or once every other month, just basically with a quick check-in. As far as diversion management goes, this is something that we watch for and we maintain. My key take home here is first is if a patient is not being honest with you, there's probably some stigma that they felt either from you or from the clinic, and they don't feel just comfortable, or they feel that they're going to be kicked out of the practice or something. So when I do a drug screen is I get the results. If it's positive for something that I don't expect, I have a discussion with the patient and say, hey, I was kind of surprised, based on what you're telling me, is your urine drug screen was positive for fentanyl and negative for buprenorphine. What's going on? And have the patient provide a chance for being honest with me. And if they are, and say, yeah, I relapsed and I used here or there. I just thank them for being honest and say, let's work on what do we need to do to get you back into recovery, and how do we learn from this? How do we work together in a constructive way? I have strong disagreements that the drug screen should be made on decisions. The problem is there's false positive, false negatives for the urine drug screen. And so if the patient tells me, nope, I'm been compliant with the meds and taking it as prescribed, having relapse, then I say as well, I know the drug test is big. We're going to send this for a the patient to kind of think about it a week, and then we'll have the result. I think are actually able to do in all of our patients at the addiction clinic at UNM understand that they may get a phone call at some point and they'll have 48 hours basically to come in and bring the meds that they have with them, and we'll just do a med count to look at it. And from my point of view at the Poison Center, having safe storage or lock boxes, I think is important. I had a child who got into buprenorphine earlier this week through the Poison Center, and child did fine. But again, I think the medications are intended for adults with opioid use disorder, not pain, but opioid use disorder. And we want to try to keep that out of reach of children. So as far as the microdosing inductions, I think we already went over a lot of this, and I'm in the interest of time, I'm just not going to rehash this. And
Dr. Warwick, we can't really hear you. I'm not sure if others can.
I'm sorry, I'm having problems with audio. I was just going through a few slides, Vanessa, just because I think I covered a lot of this, and I felt like I was running a little bit short on time, and I wanted to questions in the chat.
Okay.
And this is just correct approach, and we're happy to send that out. So as far as stopping buprenorphine, and this is going to be my last 3 slides. So there's data on the optimal length of people who are in treatment. Currently the published data is limited to a year out, and information looking at 6 versus 12 months out. Every time we start withdrawing buprenorphine from patients, we start seeing relapses occurring. Therefore, the current standard of care or standard approach is that patients maintain their buprenorphine for as long as it benefits the patient. Dr. Jacobson, myself, we're currently concluding a clinical trial sponsored by NIH, looking at titrating people off of buprenorphine who are stable more than a year out. So results will still be another year to 2 years out, and I look forward to seeing that. Certainly, we're happy to update as that progresses. Patients may have a brief withdrawal period when they're tapering off. Again, we do comfort meds, and then I always do a slow taper on the meds. And so I usually decrease about 80 to 90% over the course of a month, and have the patient do as they need. And if the patient needs to stop or needs to pause with a taper going down, I have no problem doing that, and actually for the patient to let me know, and we'll take care of that. Basically how to read that with newspaper versus a 28-day paper. Again, this is like barbecuing low and slow is a better way to go with that. And if once discontinuation is done, you want to look at functional goals, monitor them for relapse, and still would recommend they engage in counseling and therapy, a 12-step group, something to keep them into into remission, or help them through that. Also consider giving the naltrexone depot injection on completion of discontinuation. The thought with naltrexone is that for the naltrexone will decrease the cravings, and we have actually pretty good outcomes in terms of survival, and especially retention to treatment, similar to buprenorphine. Once they're on naltrexone, after a couple of months, and it would just be if they help satisfy those receptors, and then if they make sure they don't relapse. With that, do you guys have any questions?